Hi, and welcome to the Dr. Coffee Podcast, your weekly blend of motivation, encouragement, education, and insight into all things medicine for junior doctors and medical students in South Africa. In this week's Coffee with Consultants feature, we hear from Dr. Mark Torres Holmes about his specialty and his path in medicine. Dr. Mark Torres Holmes is an oto-rhino-laryngologist, or ENT, with a special interest in and further training as a head and neck surgeon. He specifically focuses on benign and malignant tumours and conditions of structures within the head and neck, as well as rare paediatric airway and neck lump problems. He developed this interest while working as a specialist consultant at the Charlotte Macnaghey Johannesburg Academic Hospital for 4 years, where he was mentored by Professor P.C. Modi. At that time, it became apparent that a multidisciplinary team approach to managing complex head and neck cancers was intuitively better, and subsequently this fact has been borne out with robust evidence of improved patient outcomes and quality of life. The importance of MDTs was a feature of our conversation when I had the privilege of interviewing Dr. Mark in his practice in Sandton. Dr. Mark currently works as a consultant surgeon with the Morningside Head and Neck Multidisciplinary team who meet weekly to discuss patients' head and neck problems. Their primary goals in patient care are to get rid of cancer and prevent recurrence while implementing measures to ensure the best possible quality of life after treatment. We had an engaging conversation about the specialist training required to become an ENT and a head and neck surgeon, the perks of the specialty, the importance of MDTs in patient care, the limitations and problems that exist in both the private and public health sectors, and how to never lose your heart for helping people, amongst so much more. I thoroughly enjoyed our conversation, and I hope you do as well. Without further ado, here is Dr. Mark. Welcome to the podcast, Dr. Mark.
Thank you, Simon. It's good to be here.
So wonderful to have you with us. Thank you for making time. So let's begin with a bit of a biography. Tell us about yourself. Where did you graduate medical school from?
University of Pretoria, Tux, 2001.
And were you a devoted student?
Yes, I think I was pretty diligent in my work ethic and pretty much tried not to miss any classes.
Yep.
But I wouldn't say I was an A student. I never got super distinctions, but I was a pretty solid, consistent student, I think, yeah.
So you graduated from Tux, and then would have done internship after. Where did you do internship from?
So I was expecting to be a Cape Townian. I wanted to go to Cape Town, and I did get my first choice at Tygerberg, which was brilliant. Didn't work too hard as an intern. I really liked this medical system at the university, at the Western Cape, the Western Cape Health. It was just really well, the system worked really well there. And I mean, you couldn't get into the Tygerberg Hospital without a referral, for example. So I really appreciated that system. I did enjoy Cape Town, and I always ended up going to the beach by about 3 o'clock. So I had a really good time. I did not know what my passion, were at that time. But yeah, I really enjoyed my time there.
And then Tygerberg was your first choice. To say, was there anything that you knew beforehand about it that made it stand out to you as a place for internship?
To be honest, not a lot. I mean, I wanted to be in an academic unit because I felt like I wanted to be around, I suppose, mentors that could teach and train better than, say, just being left alone or in a very junior place. That was just my feeling. As I say, I wanted to be in Cape Town, so I wasn't that fussy. I mean, Groote Schuur was on the list, but it wasn't my first choice. Also, I came from Pretoria with a, Afrikaans sort of culture, and Tygerberg was also like that. So I knew I would get along and fit in well there. And I'd already heard of people who had really enjoyed the time there, so I knew I was going to be happy.
Okay, great. So for you, it was referrals, it was wanting to be in an academic environment so that you could still get continuing training and oversight.
Yeah, correct.
All good reasons. And then you said that you did your comm serve back here in Joburg. Tell us about that.
Yeah, well, so I met my wife pretty much just before I became an intern, and I didn't think I was going to have a long-term relationship with her, or for that matter, a long-distance relationship. But my full internship year was a long-distance relationship, and then my dreams of being a Cape Townian were shattered because I knew she was going to be the one I was going to marry, and so she was working in Joburg.
It's worthwhile.
Yeah, exactly. So then I decided, okay, well, I'm going to go to Joburg. Where am I going to go? And then I wasn't likely to get one of the big academic posts.
Yeah.
And so I got a bit lucky getting a position at Helen Joseph and Rahima Musa. And I spent mostly time doing orthopedics and emergency medicine, which were pretty good, I must say. They're very valuable experiences to have, particularly in emergency medicine.
So it sounds like overall being a junior doctor was a very enjoyable experience. Were there any challenges, thinking back to those days, any challenges that really got to you?
No, as I said, I think I was blessed to work in the Western Cape health system in my internship, and I didn't work particularly hard. I didn't struggle with sleeplessness because of working too many hours. I think a lot of people, depending on where they work, can be very difficult conditions. So in that respect, I was, I think, blessed. Same with also Helen Joseph. It was still an academic hospital, so I was still pleased that it was in an academic sort of area. To be honest, nothing jumps to mind as a particularly bad time. It was really a very good time for me.
Fantastic. And then after being a junior doctor, you did some MO time. Tell us about that.
So once at least once I'd finished my comm service, I knew that probably surgery was my path. And but I didn't know exactly what specialty to focus on. You do your time in the big ones, general surgery, gynae, but you don't spend a lot of time in the smaller ones. And so, ophthalmology, for example, or urology, or pediatric surgery, plastic surgery. As doctors, junior people, you don't get a lot of exposure into that. And ENT was certainly one of those smaller ones. For those of you who may remember, I mean, it's like 2 weeks, I think, in your training, and maybe as a fifth year or fourth year, depending on the department you're in. So it's not a lot of exposure. And so I decided that ENT seemed reasonable, but I applied with all of those previously mentioned disciplines, and it was actually ENT that got back to me first. And so that door opened. It's amazing how things work that way. You don't necessarily always have to know what you're going to do, but doors will open and some will close, and you follow the path of opportunity. And so that was sort of was for me. And within a month, I knew this is a really good discipline, it's a really good field for me. I like the idea of medicine and surgery being involved in ENT. The statistics when I arrived there was that you're probably only operating on 1 out of every 13 patients. So you're actually primarily a physician of the head and neck. And, to this day, I say to people that if you don't know as a doctor what's going on in the head and neck, an ENT is a good person to know or refer to answer a lot of those questions, because we have a good understanding of anatomy and physiology in the head and neck. So that really appealed to me. And then I went through the process of doing the outside time that the colleges of medicine require in order to write your intermediates.
What does outside time mean?
Right. So for me, it was, I think, nearly 2 years. So the college requires for surgical disciplines to spend time in both general surgery, as well as typically trauma, as well as ICU. So those are prerequisites. I think it's really critical to spend time in particularly trauma and ICU. It gives you a really good understanding about medicine, and it's like putting you through the fire, really, and see where your metal lies, so to speak. And I highly recommend any doctor, to be honest, not only surgeons, but any doctor to spend time in those fields. Maybe not for long, because they're stressful and very difficult to do long term. But the reality is that they make you who you are. So a very valuable time. And mostly all as sort of separate MO positions that you applied every sort of 6 months for, kind of on your own. And that was great.
Okay, great. So you said you worked as a medical officer in ENT.
Yeah.
Did you outside time?
Yeah.
Was that part of the MO time for ENT, or did they then say, if you want to come back here, we want to see you go through this?
Good question. Yeah. So I think because I had built a good relationship with the professor at Wits, he kind of guided that path for me, that, if I came back, I wouldn't have to do more medical officer time. That would be incorporated into my ENT. So I think the prerequisite for ENT was at least 6 months of medical officer time. So I didn't need to do that again, because it kind of was incorporated. And so, when I applied, I think I got lucky once again. I think that's the stressful thing for everyone, is once you've now done your time, and are you going to get a post? And that's very stressful. There's a lot of competition. You don't know what you need to do, who you need to know. And so once again, I think I was lucky because people left, and so there was multiple posts available. So I was one of, I think, 3 that got posts at that intake, which was, fairly rare, to have that many doctors leave. And so once again, I think I was blessed in that regard, but it's very stressful to wait. A lot of people ask me, is it worth the wait? If you can't get the discipline that you want, should you try something else? And I don't think there's a right or a wrong answer. I've realized that with time, you like I said earlier about doors opening and doors closing, sometimes it's okay. You have an idea in your mind that this is what you want to do. It doesn't necessarily mean you have to do that. So I think you need to be prepared to change plans. I think it's important to know yourself and what your strengths are, and ultimately, whatever you do as a path you'll be successful in. Just on that note, I wasn't sure I was going to be a doctor. My father wanted me to be a doctor, but he was an engineer. And I think back now, and I was like, what if I was going to be an engineer? I think back all the skills that I have, intuitively what I'm passionate about and what I'm good at, I would have been fine as an engineer. So I would have been completely fine with that. So it's so interesting that you don't always have to make up your mind really, really early what you want to do.
That's fantastic advice, especially coming with the benefit of hindsight.
Yeah.
A little bit of the wisdom that comes with experience. I think that's something that we as junior doctors can definitely benefit from, that it's going to be okay if you don't get into that post that you want right now.
Yeah.
And besides the 6 months of ENT time, were there any other courses? Was there any diplomas that would have given an advantage in now certain disciplines once you have done a diploma as well, to give you that advantage before you come in?
Yes. So I remember doing a couple of courses, the ATLS, the PALS, the surgical skills course. Those are all, I think, even prerequisites. I don't know if they're, optional. I think that kind of you have to do them. I think they're all valuable. I think we should be doing things as much as we can to upskill ourselves, whether they're required or not. I think we should be having our feelers out to know, where am I weak or where am I strong and how can I improve that? So, yeah.
That's a great attitude to have. That's being a doctor is a commitment to lifelong learning. And as one of my mentors said, that an MBBCH is a license to learn, not a license to practice.
Oh, very nice, very nice. Yeah, your actually learning only really starts once you're qualified. I know that you can debate about what learning really is, but, yes, you can learn as much as you want from a book, but ultimately experience cannot be replaced. You want to be able to have good experience. But yeah, absolutely, I agree with that completely.
Okay, and then reg time, you completed 4 years. Where did you do your registrar time?
So the Wit circuit rotation was Helen Joseph Hospital. My registrar post was actually there, and then Baragwanath as well as Charlotte McBeke. And I really was drawn to one of the senior consultants at Charlotte McBeke, Professor P.C. Modi. He was really a big, strong mentor of mine. I really respected him a great deal, a very wise man. And ultimately, I tried to spend as much time with him, and I think I probably did spend more time at Charlotte McBeke because of that. So I think that's another important thing to be thinking about, is who do you look up to when you're training? You'll see people who do things well, and you'll see people who don't do things well. And for me, it was very important to learn the right things from the right people. You do learn how not to do things from people as well, which is important. But for me, the value of that mentorship was really key, I think, to my approach to medicine.
And did reg time include a certain number of cases you had to do? Did you have to do a certain number of hours in theatre or clinic? What was the requirements? What were the requirements to complete your reg time besides just passing exams and being competent?
Yeah. So ultimately, in order to qualify for the college, because that's essentially the body that you register with, the Colleges of Medicine of South Africa, and with the requirements is to have a logbook. So you do have to have a certain amount of operations done over that period, usually as either the assistant or the first assistant or the primary surgeon. So there is a thorough list that you have to submit at the end of your time.
Are some surgeries more highly regarded than others? Like, can you just do grommets for 4 years?
No. Yeah, there's a list of all ranges. Of course, some of them are more complicated and some of them are more rare. For example, you don't need to do them all the time. But yeah, there's a certain amount for each procedure. it wasn't a prerequisite when I was there, but there's been a push from the HPCSA to get, MEds under the belt. And so the university essentially will give that extra accreditation where you run and now do a research report or a thesis. I think that's really important, it's valuable. Certainly it's not been one of my personal strengths. I think that in general has been a weakness of South African medicine, is that we don't prioritize evidence-based research as much as maybe the first will do. Maybe it's resources, I don't know, you really need time and money to be able to do good research, and, we do have some limitations in our public sectors. So,
yeah, I've heard that some people saying that just our sheer patient volume really hinders any kind of good academic work.
Correct. You really need to budget the time to actually do research. It's time consuming, and it's a skill that you need to learn. It's not intuitive. You actually need to start thinking in a different way in order to do good research. And so that was something that I did do, but I actually never finished. So I don't actually have an MEd when I qualified. All I have is a fellow of the College of Medicine for oto-rhino-laryngology. But I think that is a good thing. I think that people should be spending time doing it. It just helps you to be thinking more critically, when you continue learning, as you said, for the rest of your career.
If somebody wants to do an MEd in ENT now, what kind of options are there? What areas of interest are kind of burgeoning fields within the South African, I don't want to say market, but the South African healthcare system?
Good question. I'm not sure.
Are there any unanswered questions?
What is it? I mean, there's 1,000 things that studies could be done on. I mean, the idea behind a research report is not necessarily to, advance your field specifically. The point of a thesis like that is really just to get a basic understanding of how science is performed. So you don't have to do anything revolutionary. You just have to get an idea of the process. And I think that's a stepping stone for something for the future. I mean, the idea behind PhDs and essentially is like try to really advance the field. So I don't know if that answers your question. Nothing jumps to mind as something that, there's work to be done in every field all the time.
Okay, well, let's shift back to your particular field of interest and your focus of where you like to work.
Yeah.
So first of all, sell to us ENT. This is your advert for your specialty. If a junior doctor or a medical student was listening and wanted to find out, besides just opening doors and what opportunities come up, what is really the draw card of ENT? Maybe even talk to what is ENT about, because we might have a preconceived idea based on our 2 weeks of exposure, which I agree is nowhere near a true reflection of what a specialty is. So tell us what ENT is and why ENT is a good choice for a doctor.
So I think I set it up already with the idea that it's actually being a physician of the head and neck, and it's a wonderful mix between being a physician and a surgeon. So I knew pretty early on that I wanted to be a surgeon, and also was appealed by the complex anatomy. So some people shy away from that anatomy, be that as it may, it was interesting and complex for me. So I liked the challenge. Also, one of the factors that people will ask and think about is, what are the after hours work like? When you're...
what's the life?
Yeah, exactly. You don't want to have to necessarily pick a profession that you're going to be working 14-hour days for the rest of your life. Look, as you enter the private sector, you generally have a bit more freedom about how to choose your hours. But the reality is that I didn't want to be working in a profession where there was a high chance of me getting called out every night. So, orthopedic surgery, for example, or general surgery, or gynae, those are fields that I pretty much ticked off my box personally pretty early. ENT does have its fair share of emergencies, no doubt, and some of them are fairly, life-threatening. But the reality is that that was an important factor for me. My particular area of interest, as you mentioned, is moved towards head and neck surgery. So it's interesting because I certainly enjoy ENT, but I don't often call myself an ENT anymore as much as I used to. I consider myself now a head and neck surgeon. Now, a lot of people hear that term and they don't really know what it means. It's a bit of confusion because there's a lot of overlap with a lot of other disciplines.
Such as?
All right. So typically, general surgery have traditionally always been the field to do things like salivary surgery, salivary gland surgery, and thyroid surgery. There has been a move over the past many years for ENTs to take over the role of the head and neck surgeon, mostly because of our ability to examine the upper airways really well with scopes. General surgeons do not examine the nasopharynx or the hypopharynx
So
or the
then
larynx.
scope some elementary canal and nothing else.
Yeah. We were positioned when the technology arrived for us to take over that role. I think in general, the general surgeons have been somewhat reluctant worldwide to completely relinquish control to an ENT. But actually, as I said, I think it's more, not so much necessarily ENT, but more a separate discipline all on its own. The other field that also is involved often is maxillofacial surgery. So a lot of dentists, for example, will refer to a maxfac when they see something in the mouth or something that's unusual. Maxfacs, that's quite a broad discipline as well. So you get lots of different things that you do in maxfac, and one of them is oncology or tumours. And so there's that link between those three primary traditional surgeons in the head and neck, and so those three really where I think that the combination comes to be called a head and neck surgeon.
Could all three be part of the same MDT?
Very nice. So
Would you say, because I am a head and neck surgeon with ENT training, I don't necessarily need to have a max patch because we're going to have the same set of skills?
Yeah, very good question. I think you touched on something that's really critical and valuable, and that's MDTs, multidisciplinary teams. So the evidence is pretty clear now worldwide that in order to get the best outcomes, particularly for surgery, for cancer, not only best outcomes from a cancer perspective, but also a quality of life perspective, you need to be thinking about the team holistically, about the patient holistically, and ultimately, what can you do before treatment commences to optimize outcomes? So MaxPac have also a critical role to do with things like reconstruction of dental when I, for example, cut out a jaw. They may not necessarily be removing the jaw, but obviously we want to rehabilitate people, for example. And so dentition is important, and so the MaxFac may be required to, for example, do implants in the fibula reconstruction. So there is critically a member of the MDTs which are MaxFacs, as well as general surgeons. For example, PEGs. We have the need for PEGs sometimes for swallowing. So yeah, I don't think you can do everything yourself.
So while we're joking about growing scopes and taking territory from other specialists, like as you say, the MDT works together for the benefit of the patient, and at some point you have to say, who would be brilliant at this? My colleague in this department.
Correct.
So we work together for the benefit of our patients.
Patients love that. Really, they appreciate it when you're thinking about them holistically, and that they realize that you're not in it for yourself. The patient is the reason you're in it, and in working in teams ultimately holds everyone accountable, and you're all sharing the responsibilities of managing patients. It's really nothing but good.
Fantastic. So what are some of the pitfalls or negatives of being an ENT? You've mentioned some of the scope aware practice. What are some of the challenges of being an ENT?
So I think one of the problems is
or a head and neck surgeon.
Yeah.
To
distinguish. Yeah. I mean, I think one of the important things is to know your limitations. So, for example, you as a registrar will learn the basics of ear surgery, sinus surgery, head and neck surgery. But in order to really, really do that well, it's such a big field, actually, head and neck and ENT, that I think in order to do excellent work, you kind of should be trying to super specialize. And I'm not saying there's never going to be a role for a general ENT. Of course there are. And I think that it's one of the things that I've seen value in is I'd rather personally be a master of one rather than a jack of all trades, but everyone is different. So as far as I say, quality of life perspective is very good for an ENT. I think, for family life, it's not overwhelming. And so that's a benefit. As far as the negative goes, I can't think of very much else. I'm passionate about my work. I know where my strengths lie. I think any negative could be coming from the fact that maybe you're not working in your passion or not working in your proficiency. I think that's a challenge of every human being, really. I mean, we work to serve others. I mean, we should be focusing on other people rather than ourselves. And then the money that we earn is a consequence of the service to others. And I think that's something we should always be keeping in mind. And in order to serve others well, we should be using our skills and our ability that we're good at and that we're interested in to do that. And that's where we feel most fulfilled. So I think, the challenge is finding that over time. It's not intuitive easily.
Very good. I love that. The serving and then the enjoyment part. obviously you derive benefit from being paid for your work, but if you were just working for money, there would be no joy attached to it at all. Being in medicine can be incredibly rewarding, but it can also be extremely taxing if you're in the wrong field, like you say, when you feel like it's a drudgery or a bore. So what are some of the positives from being in your specialty with head and neck, some of the personal highlights, maybe some stories that can share a bit of, I don't know, the human side of neck?
Well, look, obviously I treat cancer. Cancer can be heavy. I mean, cancer affects the family more than just about any other thing. The reality is that we all suffer in this world. We all struggle with something. There will be some degree of health struggles in everyone's life. The reality is we all die. And when you're dealing with cancer, it's very much, for lack of a better term, in your face with head and neck. So it's got a very big social impact. Patients themselves have taught me a lot how to suffer well, because I think that's a noble goal. You aim to achieve the cure at the end of the road, but sometimes it's not achievable. I think that's something that I've had to come to terms with psychologically, is you can't cure everyone, no matter how good you think you are, no matter how good a team player you are. Some people just don't do well. But I think that I've gotten great satisfaction helping patients, guide them through this difficult time, giving them hope. I mean, there's always hope. We don't have control over everything. There's no certainty in this world, but we can certainly give them clarity. And I think that's what patients appreciate a lot, is when you're not clear in your ability to communicate what you know, that creates discontent and frustration. So as a doctor, I think we got to be able to communicate very well. And I think that's not something you practice easily. You've got to actually do it intentionally. And so I think the biggest take-home messages I have from patients is that we all suffer, but we should be trying to suffer well. And, I can think of 1,000 stories. Some of them end well, some of them don't, and yet I've learned something. So I don't know if that answers your question, but it's
Well, one thing that came to mind while we were speaking was the importance of emotional maturity and intelligence. We speak about EQ being as important as your IQ is.
Daniel Goldman,
Is EQ something that you think people are born with? Is it something that we can mature in? Is it something that comes with experience? What for you can help us as physicians and surgeons to really improve our emotional empathy and sensitivity to our patients?
Yeah, very good question. I think it's really critical. I mean, the science reveals how some people can be successful with an extremely high EQ, but not necessarily high IQ. So it is something that I think some people are stronger at than others. I think that you're both correct. I mean, you can be born with it, but it's certainly a skill that you can learn. How to do it. I mean, ultimately, the first step is to become aware of your own feelings and your own emotions. And so introspection is very important. To know yourself well, I think, is really good. In the Bible, it talks about quick to listen, slow to speak. This is a very important principle. Ultimately, how to
Having 2 ears of one mouth.
exactly. So I think that we generally like to talk too much. So the moment we start to listen more, I think we have better empathy. You can read Daniel Goldman's book on EQ. It's a really good one.
So what would a normal work week look like for you? You're in both private as well as public at Steve Biko. How much time are you spending in theatre? What's your consulting hours like?
Yeah, good question. Day-to-day living. I mean, so on average, a surgeon is going to be spending time in the wards, in theatre, in consulting. You mentioned my time at Steve Biko. I particularly have a passion and interest in teaching and training. I think I've been well mentored by a number of mentors. I mentioned one, I have others, and ultimately I feel like, like a river, we got to pass that knowledge down. So that's the reason I spend time there, and that's 1 day a week for me. Session employee there.
Okay, so that's actually a paid direct salary on that. It's not like you sacrifice. Well, I mean, you sacrifice your time.
They don't pay well.
What I meant to say is that you doing that, but it's not like voluntary work. Like you have a passion for teaching.
Correct.
You've taken that on board, and it's obviously taking you away from your private practice.
Correct.
But there is the possibility to have a foot in both systems, so to speak.
Correct. I think that is probably the best way to do it. So I think every surgeon or any doctor really, when they potentially qualify, they're going to be tempted to either spend time in the public sector and potentially do part-time work in the private sector. I think that's extremely difficult to do it that way. I think to be available in the private sector is very difficult if you're mostly supposed to be in the public sector. So the reality is that what I feel I am doing is a better way to deal with it. You spend full time in the private sector, and then if the posts are available, if the sessions are available, which is not always the case depending on where you work, then part time in the public sector is better, I think. I personally don't agree with doctors who spend time supposed to be full time in the public sector, and they have a private practice, and then they end up leaving their private practice or their public service way too early during the day. So I'm sure everyone has seen this. It's a real problem. We call that RWAPs, but it's not well monitored. What is RWAP? Remuneration. I can't remember.
But it basically means somebody who's like
you are
drawing that public service salary.
Yes, and you can work in. It's allowed. It's legal as long as it's done in a legal way. But it's not well monitored, and so people end up taking advantage. And so it is a problem. So if people are interested in being involved in both, as I say, I recommend rather full-time private and then volunteer your time in a part-time capacity.
Okay, so you say 1 day a week at Steve Biko. Is that correct? Kind of from 8 to 5 the whole day?
Pretty much, yeah. I'm good. I have a good relationship, a good contact with the senior people there, and so they discuss cases with me during the course of a week. We plan cases, and so it helps to have a good team in that system. Just regarding the rest of the day, the rest of the week, ultimately, my day usually starts with the ward round, and then during the course of the morning, I'm either operating or I'm either consulting. You don't know really how much time you need to do either, but the reality is that you've got to see patients in the rooms in order to book them for theatre. So I personally do believe in a good quality of life. So I'm one of those people that don't believe, working 10-hour days is good enough.
You don't work weekend?
No, I don't. I've intentionally made very strict boundaries in my lifestyle so that, my patients know, my family knows, when and where I'm working. So I work hard, but not super long. When I'm at home, I'm with my family, hopefully not interrupted too often by emergencies. So I think that's quite important to have good boundaries.
I think that's a discipline that you have to be able to put boundaries in place, as you mentioned, for the sake of your family, even for your patients, that they know they're going to get the best of you when you're there. Yeah. You're not going to be pulled away because you left an important family function to come to work. Yeah. That's very good advice. And then in your private practice, is it the same kind of split between theatre time and private consulting in your rooms?
So I operate one full day a week, but I usually also share a list with a colleague on half a theatre day, and then it's usually the rest of the time is consulting. So mostly it seems to be about half I'm busy consulting, half I'm busy operating, and then, as I say, the one day a week I'm in the public sector.
So in the public sector, patients will kind of get allocated to you. In the private sector, obviously your reputation is very important. People might get to refer to you by friends. But is there ever any argy-bargy between surgeons in the same hospital or trying to get patients? Are you ever, I want to say, competitive with other surgeons?
Yeah, very good question. I think when you enter the private practice, one of the first stresses is, where am I going to work? And then you'll find pretty quick that there are some people that don't want you to work with them. So that's the first challenge, is to actually get a position in the private sector hospital. So that's a stressful time.
Does it help building connections when you
I think so,
Registrar?
Definitely. Absolutely. I think that's never burn your bridges. Treat everyone with respect and honor, because trust me, you're going to be working with those people for the rest of your life. Don't be mean. Trust me. So once you've essentially got in a position in a private hospital, I think what is important is your camaraderie with your colleagues. One of the problems with private sector is that you're very isolated. You're very alone. You're not working in a team, with seniors and juniors anymore. You're on your own. And so one of the risks is you're not accountable to anyone. And I think the best doctors are the ones that engage with their colleagues and work with their colleagues, not only in their own field, but in other fields as well. I'm very blessed to work in a really good hospital where the camaraderie amongst the ENTs is excellent. We all get along super well. And also the camaraderie with other disciplines, where we help each other out, where we refer to each other easily and willingly, and if there's trouble, we help each other. And so I don't believe all hospitals are that way, as I say, we're blessed to be here for that reason.
Do you think it would be better to be a small fish in a big pond, like a centre that's known for your specialty, or would you rather be a big fish in a little pond, maybe heading up a unit somewhere, and then it being known as the go-to guy, even if it means you're further out?
Yeah, good question. So I have some personal experience with that. Because after my reg time, I did have a full-time public sector position for nearly 4 years, I think. And then I knew that it was going to be a time where I was going to have to enter the private sector, and I knew I was going to be a neck surgeon. Morningside is known, because of two previous senior colleagues, to have built a reputation of being a really good head and neck unit. And I actually did not get fellowships after I qualified as an ENT in head and neck. I tried and failed. I was very disheartened. To get fellowships abroad is very costly and very competitive. I didn't really know the right people in order to get those positions. And so I was
little politics involved in getting those positions.
Yeah, pretty much. I mean, I was trying Canada, the UK, New Zealand, Australia, all over those places. And, you know, as I say, I think it really comes down to who you know. And I think that, anyway, I was very disappointed I didn't get those posts. But once again, I didn't give up. I felt like head and neck was my path. And so I did start affiliating myself with my senior colleague here at Morningside, Professor Chris Joseph. And so he was one of my mentors, and he was really happy to teach and I was willing to learn. But I didn't primarily start working here. I actually, when I left, I opened a private practice in Union, in Alberton, and that's where I could find a hospital to work. And so I thought I was going to do head and neck there. And so that was the beginnings of trying to build a head and neck unit there, which wasn't established, and it was actually very difficult. I realized that, you know, no matter how good you think you are, you still need the support of the ICU and the physicians and the medical psychologists
from the hospital.
Not really. It's just that to build something just takes time, you know. And I think if I had stuck to it and if I had persisted, it would have happened. But because of my relationship with my senior colleague, he eventually said, "Come here." And so that's why I came to Morningside, and ultimately we've been working together ever since. And so I think ultimately when you have a super specialty, you do want to be working in a place that has as much volume as possible. You know, high volume centers, you no doubt going to get more work, and the better you become, the fewer problems you have, the less risk there is. I think one of the most dangerous things is the occasional surgeon, especially if it's a very tricky problem. So I think every doctor should be aware of that. Every patient should be aware of that. Not that they know that all the time, but yeah.
So already from our conversation, we've kind of alluded to it, but South Africa is a country with almost two parallel healthcare systems.
Yes.
The private sector taking about 80% of the resources and the annual spend for a little less than 1/5 of the patients. If you were to compare working in public and working in private, can we just discuss some of the differences, some of the challenges? What do you see? And especially with a view towards 5 years' time when we were supposed to start NHI and how you see that maybe I can draw you out a little bit on your thoughts on NHI and what that means for the future of South Africa.
Yeah,
without being controversial. Put your neck on the line.
No problem. Yeah, look, I think it's stressful for a lot of people. What does it mean? I think there's still a lot of uncertainty. There's also no clarity right now about, from our government in particular, about how things are going to work. So I think that is a reason for the stress and anxiety. The public and the private systems are very different systems. The reality is, as you said, there's more money in the private system. People pay a lot of money to be part of medical aids. And I think our Minister of Health doesn't like the idea that all that money is going to private systems. But it is patients' own money. You know, they have the right to choose where they want to spend their money. You know, it would be wonderful if we all knew that the resources in the public sector would be better. I think it is the responsibility of the government to improve the quality of resources in the public sector before NHI could be implemented. But there's a lot of work to be done there. As I say, one of the reasons I left the public sector is because I knew, certainly with head and neck, there were certain things that I could not do in the public sector that I knew could be done in the private just because of the equipment, for example. So that's ultimately why I knew I had to leave. The business of medicine is a tricky thing. I think that there's always going to be a natural tension between the business of medicine and
when you want to be altruistic and help people and be generous, but at the same time you need to put your children through school, put food on the table.
And maybe I can move this conversation on towards something that I think is also quite important to understand, and that's what has happened to capitalism. I mean, I'm reading a book, still haven't finished it. Some of you may know it, Simon Sinek's The Infinite Game. Very cool book talking about having either an infinite or a finite mindset. Look, essentially, capitalism in principle is a really good thing. I mean, ultimately, someone needs something. Someone can provide that something. It's mutually beneficial to both. With industrialization, we found ways to try and become more efficient at doing that. And then ultimately, greed eventually sets in where how can you be more efficient and how can you squeeze more money out of that?
Any strength taken to the extreme is a weakness. And
100%.
that's some guy who manages to gain the system and then generates $400 billion of personal wealth and start to say, okay, maybe you can share a little bit of it.
Spot on. Okay. So basically, one of the issues though is that I lost my train of thought.
So we were speaking about how capitalism generates opportunity to for personal advancement and also for innovation.
Yes.
And how that relates now to healthcare.
Yes. Yeah.
And how as a medical professional, like you have to generate an income.
Yeah. I've still lost my thought.
No worries. Maybe I can just retrace our steps a little bit. So we were saying about how so I asked you to kind of venture out into the public versus private. And then things are supposed to go forward. You then spoke to the challenges of the public system where, for example, there was just not the right equipment to do what you wanted to for patients.
Yeah.
And then NHI, in theory, is a wonderful idea.
Mm-hmm.
And I would agree with you. I think there's so many people who need access to good healthcare. I think that it's almost farcical that 2/3 of specialists are in a system that only helps 1/5 of patients. But at the same time, you can't blame doctors for wanting to have a meaningful career. We work long hours, we study for long years to get where we are, and it's not our problem that there are such systemic failures. South Africa, I believe, only has one doctor for every 3,200 patients. I think that's the recent stats. And it's getting worse because of a brain drain. I don't know if this is now helps to just jog the memory. If not, we can always move on.
Yes, I finally remembered.
You found the string.
Thank you, sir. So I think one of the things that the book highlighted to me was why did capitalism really go wrong? And I think it stemmed from an actual Nobel Prize winner, Milton Friedman. He's an economist who wrote a paper.
Was he the reason it went wrong?
I believe so. I mean, this is what the guy in the book, Simon Sinek, argues that this is what destroyed capitalism as we know it. In 1970, he wrote this paper, and pretty much in that paper, he said that the purpose of you being in business is for the benefit of the shareholder, whereas everyone up until 1970 apparently always thought that capitalism is about the benefit of the consumer.
Wow.
Yeah.
That mindset, that paradigm shift.
Completely. And so what has that done? Well, ultimately, that's what's made I'm in business for myself and for the people who I must support as my investors. And so we've seen it in every industry. I mean, we feel it viscerally that there's something not quite right with our world. And it's about the fact that our priorities have now shifted away from how do we serve others the best we can to how much can we get. Unfortunately, we see it politically, we see it financially. And so ultimately, we always have to be, I think, remembering that we are in it for our consumers. And for us, it's obviously our patients.
Yeah.
So, I mean, I have a love-hate relationship with the funders. The funders are critically important. Medical aid is healthcare is very expensive. It always is. Every year it goes up higher than inflation, especially in cancer care. It's really expensive.
Is that because we're finding new ways to catch cancer?
Yeah, I think technology has a part to play for that. One of the reasons why the costs are so high is because of the administration.
Somebody the data capture, somebody has to print forms, and
discoveries spend a fortune on administration. So ultimately, I've lost my train of thought again.
So you say ultimately we're working for shareholders. The system is maybe a little bit bloated because there's all of these other structures in place that come with this. Along with the administration of it, you've got actuaries trying to calculate things. You've got people who
big data is correct. And then ultimately, when the funders come to you and they say that we will pay you this amount for this amount of work, you think that it's fair, you think that it's right, but the reality is that it's not. You're worth a lot more than you realize. And it's your choice to decide, well, am I worth what the funders tell me I'm worth, or are you worth more than that? And so I think it is a responsibility of every doctor when they enter the private sector to try and understand that system. It's complicated, it's difficult. Whatever discipline one chooses, there are societies involved. Like there's the ENT society, and in fact, that's one of the things that I'm on the executive committee of the ENT society, particularly in the coding committee, to understand coding and understand how to bill properly. So I think it's important that every doctor realizes that they can't stick their head in their sand with regards to how to code, how to bill. And I think it's wise to be understanding the business of medicine. You don't have to understand everything completely, but I think it's important that you don't make it someone else's problem. That's one of the things why I got involved, is I realized that it was a real problem. And I realized, well, if no one else is going to do it, someone's got to do it. And I think we should all be having that sort of mindset.
It's clear that that's one of your passions.
Yeah.
Is the solution maybe lying in getting more involvement from the actual doctors and medical professionals themselves?
Correct.
And I don't know how the system works. Are there medical professionals contracted in as advisors? Are they drawing from our experience on the ground? Like, how does it actually work?
Yeah, so the funders often don't pay doctors to be medical advisors. They often will pay relatively junior medical practitioners, so sometimes nurses or GPs, but they don't have really, really good financial advisors, or at least, medical advisors. So
how's a GP supposed to describe the intricacies of being a head and neck surgeon?
Correct, 100%. And then this is a problem. I mean, ultimately, when you enter the private sector, you've all heard of things called you have to get authorization, and then you have to then motivate for things to get done. I mean, these are all, for lack of a better word, bureaucratic ways to control the system. But it is a complex system. By no means is it easy to understand. But I think that, as I say, for individually, we all need to do something to try and understand and be involved in that system. I think if we involved with societies, ultimately the value of the societies is to stick together, and then ultimately challenge the big guys with the big data. I think that's another thing we all need to do, is we actually have to collect our own data. The private sector does not do well collecting its data. There's no legislation for it. We don't have to prove to anyone how good we are. HPCSA gives us a degree and says, you're good. But we all know some are better than others, and so
to be CPD and stuff along the way.
Correct, sure, that's important. But yeah, I think that we have to actually start measuring outcomes that matter to patients. And so that's a responsibility that we should all have. But there's a lot of work to be done there.
What about things like Google review? We live in the age where it's just so easy for somebody to share their experience and to even go viral. Somebody can complain about you on social media, and it doesn't matter if you've helped 10,000 people, one person who left disgruntled. Do you think there's a place for that? I mean, when I looked at the Google reviews for this hospital, for example, I was amazed at how many 5-star reviews there are, and then for how many 1-star the reviews with kind of no middle ground.
Isn't that the case with all things? If you look at Amazon, if you're only super happy, then you'll put a 5, and it's normally the people who are terribly miserable.
Most people aren't motivated to review a hospital unless they're either super happy or very, very upset. And do you think that there's any value to that? I mean, you were talking about measuring outcomes that matter to patients.
Yeah.
Is the outcome kind of as they're walking out how they feel, is that worthwhile, or do we need to analyze a little bit deeper based on maybe their long-term mortality, long-term morbidity, things like that?
Definitely. So I think outcomes can get very complicated, but as we just said, it's about the ones that matter to the patient. So as you correctly said, how they feel when they leave the hospital, how soon it is that they get back to work, how mobile are they, can they talk properly, can they swallow properly? These are all very important things.
The MDT coming back into it.
100%, exactly. For me as the cancer surgeon or the head and neck surgeon, I'm always thinking about overall survival, 5-year survival, disease-free progression. All of these things are critical. I individually, check my own numbers, but I think corporately as a group, we still got a lot of room or at least still a lot of work to do in order to be able to collect all that data for all the different disciplines and bring it together. can get very expensive and complicated with different IT systems, but, we're trying to keep it simple. But we're not there yet, Surprisingly, in this country, there's still no legislation regarding electronic patient records. I think it's just because it's so expensive, in America.
Yeah, we've got load shedding. We don't really have a reliable power supply unless you have big UPSs to drive your van to capture a computer. But if you see the experience of our colleagues in America, like they have a lot of frustration with the electronic health record. And
the admin burden is very high.
Yeah, and again, coming back to billing, how you bill, and you have to have certain things, otherwise you're not going to get paid.
Yeah.
I've got a couple more questions. This has been a really enlightening conversation so far, really engaging. I'm just so grateful for your extra insights into so much more than just ENT and head and neck. So thank you so much for that. I really mean it from a junior doctor point of view. It's nice to see someone so passionate about things that are really going to affect us in a few years' time. And I want to take the next question in that direction. Within head and neck and ENT, what is kind of like the evolving, changing landscape for your specialty? What do you see in the next 10 years really happening? Because our generation is going to come after you. And what's going to change for us? Will there be more robotic surgery? Will there be more kind of telemedicine involved? What are some of the things that you see happening?
For sure. So I think technology is always going to be a big part of how we progress. Obviously, the basics will still be in place. ENT is predominantly, either rhinology, skull base, pediatric ENT, then there's head and neck surgery, and which one I've forgotten, otology and neuro-otology. So they're all very super specialized disciplines on their own, and the technology, particularly in image capturing, is ever improving. So I think that's going to be, because we do rely quite heavily on scopes and cameras, things like that. So that's going to be ever increasing improvement there. I think the future of medicine really in general, and it's going to involve my field as well, but it's essentially the team approach, where it's obvious in head and neck where, as I say, we've got patient at the center, but we also have to get patients involved in prosthodontic care, swallow therapy care, physio care, and so that multidisciplinary team approach is very valuable in my field. Maybe a little less obvious in some of the others. For example, in otology, you might work with an audiologist. But still, I think the trusting team approach is going to become more and more important. I think the hospital groups eventually are going to have to adapt to that, because not every hospital should be doing everything, if you ask me. Some hospitals are already stronger at some things and not others. But I think the philosophy still in this country is about being a friendly neighborhood hospital that can do everything. You don't need to go anywhere else. I think that's going to fall away eventually. I think there's going to be head and neck hospitals. There's already eye hospitals, and there's already urology hospitals, but there's going to be these specialized centers of hospitals where the multidisciplinary team is involved. I think going forward, we need, as junior doctors, to be thinking, how do we work in teams? I think we're not going to be alone in the future. We're going to be having to think and work in teams, and be leaders of those teams. So I think that is hopeful. That's going to make us better doctors, really.
That's tremendous. And then if you were to really shape the mindsets of junior doctors and medical students now, what is something that you'd love for them to know? What is something you'd like them to embrace? Kind of like, what's your sounding off, your parting words to junior doctors, especially because they might not see you for very long in the ward with the 2-week exposure to ENT. If you want to leave an indelible mark on people's hearts and minds, what is it that you can leave them with?
Yeah, well, I think I already mentioned one is have an attitude of serving others. Thinking about others first, I think is really important. As I said earlier, to learn to communicate, to have emotional intelligence is really important. Those things have held me in good stead, I believe. One of the others is just to stay curious. I think it's really important to be curious, to ask questions, not in a mean way, but in a kind way, both of your patients and your colleagues. Curiosity is, I think, foundational to advancing field. Coming back to maybe empathy, but humility. I think the best surgeons are the humble ones that have the ability to accept when they're wrong, admit when they're wrong. You have to have people you trust to work with. As I mentioned, trusting teams. It's very difficult to be trusting in the people that you don't trust. So build people around you that are trustworthy, and yeah, I think that would probably be my final thoughts.
So if people did want to reach out to you to learn more a little bit about head and neck, about the cancers that you treat, about ENT as a specialty, do you have any socials we can follow you on? How do people get a hold of you if you can make yourself available to them?
So I'm a child of the 70s, man. I was born in the 70s, so I'm not super strong on the social media. I have a website. Will that help? Yeah, probably. I think it's Dr. Torres Holmes.
He's reaching for it.
For God, yeah, exactly. Dr. Torres Holmes, that's .co.za.
Put that in the show notes.
Thank you. Excellent. I actually have recently started a blog. Basically, I think it's my responsibility as a head and neck surgeon to help fellow colleagues understand our discipline better. So I started a blog on my website where it's basically focused on my referral patients, my referral based rather, GPs, things like that.
So one final thing, Dr. Mark, if students were wanting to do an elective with you in ENT or head and neck surgery, how can they get a hold of you and how can they go about doing an elective? Do you have any requirements, any prerequisite reading that they do before they come and work with you?
No, not really. No pre-roll.
The zones.
Levels, actually, not those.
I blame my 2-week exposure.
Yeah. In fact, the general surgeons call them zones, and us head and neck surgeons call them levels. Anyway, there's no prerequisites. I have had a couple of people ask, and I've had some, the pleasure of having people shadow me in theatre as well as in the rooms, and I often talk too much, so I think they enjoy their time with me. I hope. My contact, it probably is going to be best through my rooms. So, yeah, exactly. Perfect.
Yeah, thank you so much for making yourself available. It's been an absolute pleasure to pick your brains, get your thinking on some important matters, not just related to your specialty. It's been an absolute blessing to get your experience, your wisdom, and to just get a little bit of view on the podcast. So thank you for being on the Dr. Coffee podcast. We look forward to hearing more from you in future.
Oh, thank you, Simon. It's been a pleasure. All the best, guys.
I hope you enjoyed this week's episode as much as I did. Full links to websites and resources mentioned can be found in the show notes for this episode. If you know of a consultant or a senior registrar in a specialty that you would like to be featured on the Dr. Coffee podcast, please get in touch. The podcast's email address is drcoffeeza@gmail.com. That's drcoffeeza with no punctuation marks. We're also on Instagram, Twitter, and YouTube with the username @drcoffeeza. If you've got anything else on your mind, such as a request for additional topics, further information on how to engage with our guests, feedback on the show, or anything else, please get in touch. We'd love to hear from you. The Dr. Coffee podcast is brand new and freshly brewed each week with you in mind. Please consider sharing this episode with fellow junior doctors and medical students in your world who you think would benefit from the content and enjoy it. You can also help by posting a picture of your favorite warming beverage on Instagram and mentioning @drcoffeeza. We'll repost every mention to our story. Thank you so much for your support.